Good afternoon, everyone, and thank you very much for inviting me to deliver this lecture today. I'm really grateful to Underdetection Medical Association, and thank you very much, Professor Anjali Silla, for that kind and generous introduction. So today, this like half an hour also, I'm planning to talk about delirium. This is not a kind of a specialty of psychiatry. I mean, so any one of us come across patients with delirium, and so it is really important for us to know how to identify and manage. And I'm quite sure, so all of you are well versed with identification, screening, and management of delirium. This is just a kind of a update ourselves, or kind of a raise in the awareness. I would rather say this is kind of a raise in the awareness of delirium. It is really important to improve the outcome of patients, right? And so delirium, I would say it's a kind of a phenotype, and this is sometimes a presenting symptom of delirium. So whatever it is, and if you see GI surgeon, and some the decompensated cirrhosis can present as delirium, and renal, and if you say that, you will see the acute renal failure can UTI can present as delirium. In parasitology, if you see that, the cerebral malaria can present as delirium. In medicine, myocardial infarction, the hyponatremia, hypoglycemia. So any condition can present as delirium. So the delirium is just a phenotype or just a presenting symptom. The most important thing is to identify the underlying cause. So with having that in the mind, and so this is the layout. So we planning to talk about impact of delirium, and improving the diagnosis of delirium, and optimizing the care and the prevention. And first, I would take this. We took this a couple of years ago as a referral, and to us, a 60-year-old man was admitted to the ward for treatment of uncontrolled hypertension. Nurses observed that his behavior changed 2 days after the admission, and referred to psychiatric unit for an assessment. He thought that nurses giving him poisonous medications and security personnel coming to the ward to find his details. He was escaped from the ward and found wandering on the hospital premises. Because he was just wandering and found on the hospital premises, they have referred us for an assessment. So you can see that mainly the psychotic symptoms. So what is the possible diagnosis here? So keep this in mind. So we'll come back to this question later on. Right. So diagnosis of delirium. So in the medical student days, we think the diagnosis of delirium is just not knowing the time, not knowing the place, or not knowing the month or person, not being able to identify you kind of as a doctor or nurse or someone, right? But this is, so if we go by this, we'll miss a large number of patients with delirium, right? So it is something important for us to remind ourselves some of the features of delirium. The one possibility is the acute onset. I mean, if someone on the wall notice acute behavioral change, the number one possibility is delirium. Patient is well, suddenly changing behavior. So you got to exclude the delirium, right? So not only the patients, and sometimes the friends among us, right? Sometimes the friends among us and the family members, if you notice sudden change in behavior, right? You might think that this man is crazy, or sometimes having a mental illness or something like that. But if it is sudden change in behavior, it is very likely that the possibility of delirium is very likely high on the count. And so that is not the only possibility, but it is really important to exclude that, because, for example, the patients with diabetes, one of our parents with diabetes, and if you notice sudden behavioral change, right? Talking nonsense and behaving bit of an odd way, if you notice that, if you do not think of the possibility of delirium, you might miss the hypoglycemia, right? If you miss the hypoglycemia, a couple of hours later, you will see irreparable damage, and sometimes it might cost life, right? So any change in behavior is really important to understand the possibility of delirium. And inattention is not really in the sense of not knowing the time, right? Inattention, they are very much distractible. And if you see your patients of someone is very much distractible, the one of the possibility is delirium. Actually, inattention is the cardinal feature of delirium. So that is how textbook described it. And disorganized thinking. When we talk to the people, and you will realize that they are not kind of giving right answers to what you ask, and their thought is very much disorganized, right? And if you see, the brain is compromised to some extent, especially in old age people. So their information processing is very much slowed down. Information processing is very much slowed down. And in the context of dementia or some Parkinson's disease or something like that. And if you see this, the disorganized thinking in the context of slowed down information processing, so that is again, if that is on top of the cognitive impairment, that is again the possibility of dementia high on the card, and disorientation, memory impairment. So long-term memory impairment is not a delirium, but if you see a patient who is having a good cognition, and all of a sudden, if you realize that patient is very much forgetful, and that is one of the possibility. And actually, one of the post-operative patient referred to us the thinking of the possibility of dementia after the surgery, right? So we found out that patient is having just hyponatremia, right? So if you kind of just superficially assess the patient and kind of given the label as hyponatremia, patient would succumb to hyponatremia, right? So that is the importance of kind of having a detailed assessment for delirium, screening for delirium. Another one is perceptual disturbances. So this is one of the common thing. The patients with delirium are having perceptual disturbances like visual hallucinations, auditory hallucinations, and tactile hallucinations. They are become very much paranoid about people around. So that is one of the things. And the psychomotor agitation and psychomotor retardation. So psychomotor agitation, you just imagine a patient is got very agitated in the context of psychosis or whatever thing in the medical casualty or surgical casualty ward. The ward people may not be able to manage that. Among the many other urgent cases need to be attended, right? So that is something really important to think about the possibility. Other one is retardation. So on the ward, this patient is not disturbing anyone, right? When you wake up the patient, give medication or food, you realize that patient is disoriented a bit, right? So if you did not detect this hypoactive delirium, so patient will silently pass away, right? Because there is a significant underlying cause when someone presented with delirium. So hypoactive delirium is, the mortality is very high, not because of anything else, we do not detect that. And the altered sleep-wake cycle, so this is typical textbook things. The other important thing is patient experience of delirium. So most of the time we struggle in the medical ward, surgical ward, neurology or whatever the things, the patients can be very much disturbed, right? So you can't comprehend what is going on. And patients with delirium, they are frightened. They are very much anxious about the surrounding, right? So if you look at, I mean, there are enough and more videos in the YouTube about the patient experience. One of the patient, around 1 a.m. in the morning, called his wife, saying that there are a lot of bombs set inside the boat, and at any time they will go off. I'm going to die in a couple of hours. I just calling you to say goodbye, right? The wife was telling that she couldn't made up her mind what to say, just to say, I mean, no, you will be all right, or just to say, thank you for the last 50 years, if that is the case, right? So, I mean, so that is the thing. So in the morning when they go and assess the patient was delirious, there was no bomb risk or anything like that. So that kind of the paranoia is can be seen in patients with delirium. So it is, they see very strange animals, they see very strange things, they see people are trying to get in at them, and they see the doctors with stethoscope. They are coming to strangle them and things like that. So these perceptual disturbances and paranoia is real to them. So that is something. So in that context, if we do not understand this patient experience, and if we treat them kind of a bit of a rough way, saying that don't do this and that, so they will get really scared, right? They'll be very helpless, right? So that is something really important to understand the patient experience in the management of the delirium. And this is in cultural way also. You might have heard in good old days, our grandparents says that the මෙයා ලොකු තාත්තා මැරෙන්න කිට්ටුව කිව්වේ යා ගින්දර දැක්ක යක්කු දැක්ක පෙරේතයෝ දැක්කා ඊට පස්සේ probably he might have gone to hell, something like that. අපායට යන්න නැති අපායට යන කලින් ඉඳලා දකින්න නැති අර මේ වගේ කියලා. So before the death he might have had hypoglycemia or hyponatremia, UTI or something. So he might have seen those things. ඊට අමතරව දැකලා තියෙනවද මැරෙන්න කලින් මිනිස්සු ගොක්කල දකිනවා කියලා කියනවා. So this very likely the visual hallucinations in the context of delirium, right? So when you are deliric, though your mortality is very high, when you see gokkala, it is very likely that you die in a couple of years, right? Yeah. So first, the impact of delirium. So why we need to be really aware of this condition, why we need to really screen the delirium, right? So delirium, so if it happens, so there is an 8-time risk of developing dementia, which is irreversible condition, right? And there's as I discussed, the patient distress and the carer distress. More than anything else, distress to the healthcare team. So likewise, in the middle of the casualty day, how you can manage this, right? So it causes huge distress to everyone. And 20% mortality in 3 months' time, right? And 20% do not go back to the baseline, right? All these meta-analysis findings tells us that 20% do not go back to the baseline. And the healthcare cost. In Sri Lanka, we haven't kind of systematically evaluated the healthcare cost for the delirium, but in developed countries, they have evaluated like millions of dollars and long-term cost, the healthcare and the long stay in the hospitals and the lot of other expenses, right? So it is clear that delirium has to be prevented, right? The most important thing is delirium is most of the time delirium can be prevented, right? So 1 in 8 cases of delirium preventable according to the systematic analysis. And most of the causes of delirium are modifiable. For example, you get a patient with renal failure, acute renal failure on the ward, patient having diuresis, something like that, patient get dehydrated, so patient can get delirious, right? And so dehydration is one of the commonest cause of delirium. The pain is one of the commonest cause of delirium in old age. Constipation, UTI, hypoglycemia, hyponatremia, fever, any infection, right? So it is really important for us to be aware of this condition, have a high index of suspicion, right? Another important thing is causes of delirium are multifactorial. That is one of the important things. So we think patients with UTI develop delirium because of the UTI. You treat the UTI, you close the case. But it's not only the UTI. There can be fever, can cause in delirium. There can be dehydration causing delirium. This can be pain, colic pain causing delirium, right? So likewise, so when you identified something, right, that is not the cause of delirium. There can be so many other causes of delirium that can be multifactorial. Actually, research has found out that this is one of the causes of long-lasting delirium. So you think because of delirium, you treat with antibiotics and you leave the case, but patient continuously experience delirium. Right. The prevention of delirium. Now this is the delirium. So delirium management and prevention These are not rocket science. Very simple things we can do. We can save many lives, right? Prevention of delirium. So out of these things, what is the most important thing to prevent the delirium? So research has shown across the globe the most important thing to prevent delirium outside the patient. That is staff education. Educate and raise the awareness of delirium and do systematic analysis, systematic screening of delirium. So this is the most important thing. We need to be, are we educating our staff on delirium, right? So this is something really important. This is the most effective thing. This doesn't cost anything, right? So this is our response. One of our responsibilities to educate our staff, not only the doctors, nurses, and other staff, just to notice the change in behavior. And then doctors try and identify the cause of delirium, right? So this is the something most important one. So we actually thought of kind of doing with the medical wards and our geriatric team do about the educate about the delirium in the hospital setting, right? And improving the diagnosis of delirium. So internationally, there are a lot of research. They have shown that up to 60% of cases of delirium are underdetected in medical setting. I'm sure in Sri Lankan setting this is much higher. 60% of cases are not being detected. You can understand what would happen to the 60% of patients, the fate of the 60%. Their individual suffering, their family suffering, long-term mortality, and the morbidity and everything. Right. So why do we miss diagnosis of delirium? Right. Then the number one thing is lack of awareness. So this is the case across the job categories in healthcare system, the doctors, nurses, specialists, and other supportive staff and everyone. So this is lack of awareness identified as a major problem, not only in Sri Lanka, in other countries as well. And lack of systematic analysis, systematic screening. So in other pediatric units, and so most of the time they screen for delirium. In our setting, because of very heavy caseload and patient turnover and everything, this is not happening. Right. Other important thing is presentation simulates symptoms of mental illness. Right. So we think delirium is not being oriented, but commonly they present as a symptom of mental illness. They just pass it to a mental health care team, right? But delirium is a medical emergency. Okay. And so they might be very paranoid and hallucinating and agitated, disturbed behavior, very difficult to contain on the board, right? So they present as symptoms of mental illness, right? They overlap with other psychiatric diagnoses, like people think this is the possibility of, because of this memory problem, acute memory problem, people think that this is dementia or something, right? Or depression or something, right? The other one is the hypoactive delirium. The patients are very much withdrawn, not talking, but you see patient is delirium, right? And so because of these reasons, the delirium, the hyperactive delirium is actually the commonest cause of delirium, commonest subtype of delirium, right? So most of the time, the hyperactive and mixed, and more than 40% of time in Sri Lanka and other countries, it is hyperactive delirium. That is why it is being missed quite a lot. There's a very interesting joke running, and so they think that in the medical team, they think the delirium is a psychiatric the condition, and the psychiatrist think that this is a medical condition, right? Then deliric patient think that where am I belongs, right? Then deliric patient thinks where should I be managed, right? So actually the management, so that is what we all practice in the teaching hospital Anuradhapura. This is we liaise with the medical team and surgical team. So we psychiatric team go and see the patient, and medical team identify the underlying cause, whatever the brain tumor or hyponatremia, hypoglycemia, UTI, they treat that. So we do the behavioral management and the psychiatric symptoms. So that is how it's been managed. So it is more of a collaborative work. This is a medical emergency. Right. So if you look at the first question I asked after the case scenario, so what is the most likely diagnosis? Now I change the question. If I change the question, you might have thought that there could be kind of more than one questions here, more than one right answers here. It's like SBA. But if I change the question, what is the most important diagnosis needs to be excluded in this scenario. Now there you get only one answer. You agree? It is delirium, acute medical emergency. Right? Okay. So this is, we did recent research, one of the post-MD dissertation, and among 233 patients in our hospital, the prevalence in medical wards, it's 20.3%. Right? And prevalence in general surgical wards, it's 11.5%. You can see that 1 in 5 people over the age of 60 in medical wards are having delirium. Right? So we miss quite a lot of patients with delirium. And 1 in 10 patients, older adults in surgical wards, are having delirium. So we again miss quite a lot of patients with delirium. And in our hospital, the hyperactive delirium is 40.5%, and hyperactive delirium is 33.3%, and mixed type is nearly 25%. Right. And implications of misdiagnosis of delirium. So we can see that in our setting, in the country and globally, we miss the diagnosis of delirium. So what are the implications? So you can see that huge distress to the patient, family, healthcare team, right? Increased mortality. They are not being coming back to cognitively to the baseline, risk of dementia, which is irreversible, right? And the healthcare cost, right? If you miss the diagnosis of delirium, so there can be a lot of reversible causes, right? So like hypoglycemia, hyponatremia, UTI, very simple ones, right? You might miss the possibility of getting the patient back to normalcy completely. You might miss that opportunity. So that is why we call it as a kind of a presenting symptom. Delirium is a presenting symptom. It is really important to pick it up. And so if you miss, there can be a permanent consequences. Right. So management of delirium. So in any setting, the understanding patient experience is really important, right? So understanding patient experience is really, really important, because you might see this patient as a nuisance, right? Troublemaking person on the board. But if you really look at the patient experience, patient is really frightened. They are really scared to death, right? So it is very unfortunate that sometimes the patients with terminal illness, in their like the last couple of hours, they are suffering a lot because of the delirium, right? So when I underwent the surgery once in Kalubowila, there is the SIDU, and so there's myself and there's the patient, and that patient is very much renowned chemistry teacher in Colombo. And so after the post-operative surgery, he was very much deliric, and he's really scared of me. Really scared of me, the myself and only him. And there's one of my friend called Anand, is a very good psychiatrist, and he tried his best to kind of reorient and reassure him and talk to the doctors and everything. They just came and give him diazepam in the morning, so they might have increased my analgesics as well. So I fell asleep, and when I wake up in the morning, so because of nuisance, so you call the nurses, and this patient needs your support and help, right? And in the morning, it is very unfortunate that the patient passed away, right? So you can see that last couple of hours in his life, right, lived in extreme fear, anxiety, and terror, right? So this should not happen if the staff kind of are keen enough. That was a major surgery. I think the mortality is very high. But they might find a kind of a reversible cause. So that is the importance of identifying the delirium, the patient experience, which is something really important. Right. So when it's come to the management, the there are two things. One is non-pharmacological and pharmacological management. So if you look at the evidence, if you look at carefully the evidence, the methodological rigor of the studies and the meta-analysis and systematic analysis, so you have only the effective evidence for non-pharmacological management. Right? So non-pharmacological management is the one we have evidence, right? So that is something really important. In non-pharmacological management, if you look at, so you don't need an expert, right? Again, if you can teach your staff about the non-pharmacological management of delirium, right? Just reassure the patient, right? Saying that, so your mind is playing trick on you, right? So this is not the reality. You ground the patient, reassure the patient, reorient the patient, right? So that is very helpful. Identify the reversible underlying cause and things like that. That is very helpful, and that is what is most important. And pharmacological management, so you will see, if you look at the research carefully, there's no evidence for pharmacological management, right? The most of the time, we treat the patients with pharmacologically we treat the patient, right? So pharmacological management has to be low dosed and shortest duration of time. So you use pharmacological management only to reduce the harm. It's just a harm reduction. It does not alter the course of delirium. It does not shorten the course of delirium. It does not treat the cause of delirium, or it does not kind of shorten the duration of delirium. In fact, pharmacological management can worsen the delirium. So you know that organic brain disorders, if you use antipsychotic medication, it can increase the conditions like neuroleptic malignant syndrome and other things, right? So that is something really important to understand. Use your pharmacological management sparingly, right? So these are the most effective and evidence-based interventions for delirium. So you can see that, so anyone can do this kind of things, right? Modify patient surrounding. Patient, you give some the cues to understand what time of the day is it, right? And the sunlight, the clock and things like that. And reassuring environment, because patient sees lot of things are threatening, you just reassure the patient, right? So they are deliric and they have hallucinations and delusions, but they can be reassured. So that is the most important thing. So you put a kind of photograph of their children and wife or family or something, the familiar to them, just to ground them, right? And improve vision and hearing, which is very, very important. And proper environmental cues, manage pain, early mobilization. And that is one of the best evidence for post-surgical delirium, management of post-surgical delirium, early mobilization, prevent the delirium, right? And improve sleep and reorientation the patient and consistent care. So because patient, there's a processing abnormality in processing of information. So in one shift, you can allocate one nursing officer to attend the patient, right? Then the patient will not misinterpret the information, the consistent care, right? So coming back to pharmacological management, right? Not a substitute for non-pharmacological management, right? So we all know, we all are busy. We find it difficult to kind of deliver non-pharmacological management, but it takes just 5 minutes, right? If you can get one of the nursing officer trained, and it is not rocket science, it's very easy to train anyone, even the supporting staff member can do this, right? And if you train your staff adequately, and you can do that, right? Only use for harm reduction. If patient is very much disturbed, right? What I use pharmacological management most of the time, if patient is delirious patient is, and they badala dala tiyenawana, restraint kala tiyenawana, right? So you can see that such a frightening person, anxious and scared person, if you have tied the patient to the bed, you can imagine patient experience, what it is, right? So that is where you can manage you can use the pharmacological management just to contain the behavioral problems. No evidence to improve outcome, treat underlying cause, speed in the recovery. pharmacological management. Does not cause shortening of the duration of delirium. So this is based on research and meta-analysis and everything. And so this is one of the important things I want to discuss with you. I'm sure you all know this, and just remind and refresh our knowledge. This is the updated medical knowledge. Right. Again, pharmacology can cause worsening of insight in delirium, right? And use the lowest dose for shortest period of time. Right. So we know some antipsychotic medications, benzodiazepine, anti-epileptic medication, and propofol. Right. So antipsychotic medications, there are the side effects on its own, like QT prolongation, worsening the delirium, right? So benzodiazepine, they use some analgesics like morphine as well. They're just to contain the behavior, right? It does not change the outcome. The dexmedetomidine, I can't pronounce this. So this is the latest one. This has some kind of evidence in ICU delirium. And so this is alpha-2 agonist given as infusion, and benefits include anxiolytic, analgesics, hypnotic, anti-agitation properties, lighter sedation compared to alternatives like propofol. Side effects are primarily hemodynamic, the bradycardia, hypertension, rebound hypertension, and things like that. This is yet to get the FDA approval, but out of other medications, this I'm not sure whether it's available in. Yeah, okay, right. So this is one of the newer medications which has lesser side effects. Right. So, okay, I'm on time. And so few take-home messages. Delirium is under-recognized and under-treated. And cost of delirium is huge at personal level, family, healthcare team, and the government. Healthcare cost is huge. Delirium is multifactorial in etiology. If you think it is UTI, there can be other causes of delirium as well. The mainstay of management is non-pharmacological management, right? Mainstay of management is non-pharmacological. Educate your staff to do the non-pharmacological management, which is the most effective one. The pharmacological management do not have an evidence base and use it with extreme caution. The most important thing is educate your medical team on prevention of delirium. So this is the most important thing. In the prevention of delirium, the systematic screening is something really important. Raising the awareness among the medical professionals is really, again, important, and understand that the delirium is just a presenting symptom. There can be a lot of underlying causes, and causes are multifactorial, right? So in fact, so there's in addition to that study, that there are two other current studies are going on. Dihutu is doing one, and for the screening, so we validate a tool to our culture to detect delirium, to give our healthcare staff to increase the detection of delirium. There are two, the 4A and CAMS, the tools we are validating in Anuradhapura. So we are more than happy to work with, as a mental health team, we are more than happy to work with the medical, surgical, or whatever the specialty to manage the patients with delirium. And if you think we can help out to educate your staff about the management of delirium and raising the awareness and things like that. Okay. Thank you very much.